everyone, and welcome to today's rounds presentation on influenza, COVID-19, and RSV vaccines for the 2024-25 respiratory season. My name is Tara Harris, and I'm the manager of the Immunization and Vaccine Preventable Diseases team at Public Health Ontario, and I have the pleasure of moderating today's session. I'd like to acknowledge that the land I'm joining today is situated in Toronto, which is the traditional territory of many nations, including the Mississaugas of the Credit, the Anishinaabe, the Chippewa, the Haudenosaunee, and the Wendat peoples. Toronto is covered by Treaty 13, signed by the Mississaugas of the Credit, as well as the Williams Treaties, which were signed with multiple Mississaugas and Chippewa bands. Today, this land is home to a rich diversity of First Nations, Inuit, and Métis people from across Turtle Island. Please join me in acknowledging all Indigenous peoples, their worldviews, and their indigeneity. May we honor and respect the connections, relationships, and life journeys of Indigenous peoples, acknowledging their enduring ties to the land, skies, and water since time immemorial. Before we begin, I'll mention a few housekeeping items. The chat pod has been disabled for the duration of the presentation. Please use the Q&A pod if you have questions during the session. A question and answer period will follow the presentations, where we'll focus on questions related to the vaccines and immunization programs covered during the session. If at any point you experience any technical issues, please email capacitybuilding@oahpp.ca. And finally, as the moderator of this session, I do not have any conflicts of interest to disclose. So the learning objectives for today's session are to describe the immunization products available in Ontario in the fall of 2024 for influenza, COVID-19, and RSV. We'll summarize the NACI's recommendations and provincial guidance for Ontario's influenza, COVID-19, and RSV vaccine programs, and identify resources to support immunizers in their delivery of Ontario's influenza, COVID-19, and RSV immunization programs. It's now my pleasure to introduce the speakers for today's presentation. Dr. Sarah Wilson, who will be speaking on COVID-19 vaccines, is a public health physician in communicable disease control at Public Health Ontario and works with the Immunization and Vaccine Preventable Diseases team. She's an associate professor at the Dalalana School of Public Health at the University of Toronto and a senior adjunct scientist at ICES. She's a member of Canada's National Advisory Committee on Immunization and has been the chair of the NACI COVID-19 Working Group since 2022. Dr. Richard Mather, who will be speaking on influenza vaccines, is a public health physician in communicable disease control at Public Health Ontario and works with the Communicable Diseases team. He's an assistant professor at Queen's University in the Department of Family Medicine and has a Master's of Science in Control of Infectious Diseases from the London School of Hygiene and Tropical Medicine. And Dr. Reid Morrison, who will be speaking on RSV prevention, is a public health physician in communicable disease control at Public Health Ontario, working with the immunization and CD teams. He's an assistant professor at the Northern Ontario School of Medicine University. I'd also like to introduce Dr. Daniel Warshafsky, who will be joining our presenters during the Q&A session. Dr. Warshafsky is an Associate Chief Medical Officer of Health and oversees the immunization portfolio in the Office of the Chief Medical Officer of Health at Ontario's Ministry of Health. He's an adjunct lecturer at the University of Toronto and an adjunct professor at the University of Ottawa. Our speakers today do not have any conflicts of interest to disclose. And with that, I will pass it over to Sarah Wilson.
Okay, excellent. Well, thank you so much, Tara, for the warm welcome and introduction. And I'm pleased to give the first presentation today focused on COVID-19 vaccines and guidance for the fall of 2024. So with this slide here, I'll direct your attention to the figure on the left. And this figure represents COVID-19 and influenza hospitalizations in Ontario from January 2023 up until last month. You can see that COVID-19 hospitalizations are represented in blue and influenza hospitalizations are represented in yellow. And I've included this figure because I think it's important as one of our messages here that although COVID-19 does not yet have a clear seasonal pattern, we do reliably see increased COVID-19 activity in the fall and winter months, and this overlaps with the circulation of other respiratory viruses such as influenza, as shown in the figure, as well as RSV. And the other reason for including this is just as a reminder of the ongoing important burden that COVID-19 represents in terms of population health, as well as impacts on the health system. You can see this represented in terms of just the absolute magnitude of COVID-19 hospitalizations. And I think this is important as we reflect on the opportunity for COVID-19 vaccines to prevent and provide protection against this important outcome. So why is an updated COVID-19 vaccine needed this fall? And so part of the answer to that question is included in this visual illustration. This is a figure that represents the SARS-CoV-2 genomic surveillance work done by our colleagues at Public Health Ontario. This is a figure that represents approximately 1 year, so going back to September of 2023 up until last month, and tracking the changes in the SARS-CoV-2 virus over time. And the different sublineages as the virus evolves and changes over time are represented in the different color schemes included in the figure. So as SARS-CoV-2 virus evolves with these different sublineages emerging, it's important that COVID-19 vaccines are updated as they have been in recent years to provide the best protection possible by having a closer match between the variant or the sublineage contained within the vaccine and to match this to what's predicted to be circulating in the fall and winter months. So this fall, in the fall of 2024, the COVID-19 mRNA vaccines will target the KP2 sublineage, and this is based on a decision made by the FDA in June of 2024. So next, how well did last year's XBB-containing COVID-19 vaccine do in terms of protection against hospitalization? And I've included this slide because I think we can potentially draw some reflections and some inferences in terms of how well last year's vaccine did, in terms of thinking about how well this year's fall 2024 vaccine might do. So this is a figure that represents vaccine effectiveness. It's looking at individuals who received last year's updated vaccine, so the XBB containing vaccine, and compares vaccine effectiveness, so looking at the protection against hospitalization in individuals who received the vaccine versus those who did not. It includes several different adult age ranges and also looks at vaccine effectiveness at various points in time since the vaccine was received. This figure is taken from a publicly available presentation given to the Advisory Committee on Immunization Practices in June of 2024, and I've selected it because it has follow-up time out to almost 6 months. And I do also want to note that there is important work underway in this area by Ontario colleagues, Jeff Kwong and others, with very similar findings that will soon be available in the public domain. So I think one of the key messages of this very busy figure is that the updated COVID-19 vaccines last year provided increased protection against hospitalization compared to those individuals who did not receive an updated vaccine. And we'll discuss this in more detail on the next slide. I'd like to focus your attention on the bottom portion of the figure, which highlights vaccine effectiveness estimates for older adults, so adults 65 years of age and older, and looks at vaccine effectiveness in this particular population. Again, comparing those who received an XBB containing vaccine with those who did not. And you can see that the vaccine provided increased protection against hospitalization in the range of 43% at 2 to almost 4 months after vaccine. And this did wane over time down to 13% at almost 6 months post-vaccination. And this is part of the rationale for why in previous years there has been a recommendation for those at highest risk of COVID-19 severity to receive an additional dose in the spring. So let's move on next to the NACI recommendations for the fall of 2024. These are summarized in the statement included on the slide there, and I'll just briefly highlight some of the key recommendations. So the key recommendations are first and foremost that only vaccines targeting the latest selected strain should be used in the fall of 2024. NACI strongly recommends COVID-19 vaccination for those at increased risk of infection and in particular for those at risk of severe COVID-19 disease. while all others 6 months of age and older may receive the updated vaccine in the fall of 2024. In regards to recommendations for the interval between a previous COVID-19 vaccine dose and the fall 2024 dose, the recommended interval remains unchanged at least 6 months, but there is some new language that articulates a minimum interval, so the shortest interval that could be considered, which is at 3 months, and there's some language in the statement that provides the rationale for this in relation to ensuring that those at highest risk of COVID-19 severity who would have received a spring dose can remain eligible for a fall vaccine dose as part of fall campaigns. And then there is also some additional language. It's framed as a consideration that individuals and immunizers may consider delaying COVID-19 vaccination by 3 to 6 months in individuals after a test confirmed infection. And again, I note that that's framed in the statement as a consideration. So let's move on to guidance within Ontario in terms of Ontario's COVID-19 vaccine guidance for this season. So this is very much aligned with the recommendations contained in the NACI statement. Individuals who are high risk for COVID-19 severity are recommended to be vaccinated as soon as vaccine is available, which is now. And those risk groups are listed in the blue call-out box on the slide. There is also additional groups who are recommended to receive COVID-19 vaccination now, and this is to optimize the opportunity for co-administration with influenza vaccine. So these are some additional populations, for example, children 6 months to 4 years of age, who are not a risk group for COVID-19 severity, but who are at increased risk of influenza. And so this group is listed, as well as staff, caregivers, and others who work with vulnerable clients, healthcare workers, and first responders, as well as a new group added here, individuals who have significant exposure to birds, poultry, mammals, etc. And my colleague, Dr. Richard Mather, will be providing additional details and rationale for this. And then later in the month, on October the 28th, COVID-19 vaccines will become available for everyone in the province who are at least 6 months of age. So briefly, I thought we'd just briefly review what COVID-19 vaccines will be available as part of Ontario's fall program. As I mentioned earlier, the mRNA vaccines will be targeting the KP2 sublineage. The Moderna vaccine will be available in dosages that are appropriate for use for children as young as 6 months and older. And the Pfizer-BioNTech vaccine will be available for those 12 years of age and older. Similar to last year in terms of a fall dose, only one dose is needed for individuals who've been previously vaccinated. And I've previously outlined some of the considerations related to the interval listed there in the slide. And then I thought I would also include this final slide here that represents schedules for individuals who have not previously been vaccinated. As you'll recall, we used to refer to this as the primary series. So this guidance, if we'll focus your attention on the table in blue, this represents the schedule for people who are not moderately to severely immunocompromised. And this is unchanged from last fall in that everyone 5 years of age and older, if they've not been previously vaccinated, only one dose is needed. And for infants and children under the age of 5, Moderna with 2 doses is recommended. There are more complex schedules for individuals who are moderately to severely immunocompromised, and that's included in the gray table with further details available in the NACI statement and provincial guidance. But the one thing to draw your attention to, which relates to an update in the fall 2024 NACI guidance, is that individuals who are recipients of hematopoietic stem cell transplants and recipients of CAR T-cell therapy are noted to be immunologically naive and recommended for a 3-dose series at the point in time that COVID-19 vaccines are recommended. So that represents some new guidance relative to last fall, and I wanted to be sure to highlight that point in particular. So the next slide here is a bit of a wrap up that highlights some of the resources and hyperlinks that are available for immunizers and healthcare providers to find guidance on COVID-19 vaccines this fall, and these are listed here for your reference. And with pleasure, I'll turn it over next to my colleague, Dr. Richard Mather, who will be continuing on with the rest of the presentation.
Thanks, Sarah. This table shows the components of the Northern Hemisphere egg-based influenza vaccine for this season, 2024-25 in the right-hand column compared to last year. This year's vaccine has one change compared to last year with a different influenza A H3N2 component that is shown in bold. The other 3 strains are unchanged from last year. Quadrivalent vaccines contain all 4 of the strains shown here, and trivalent vaccines contain the 2 influenza A strains as well as a strain from the B Victoria lineage, but do not contain a strain from the B Yamagata lineage. This year, the World Health Organization, or WHO, recommended that the B Yamagata lineage antigen should be excluded from influenza vaccines as it is no longer warranted. There have been no confirmed naturally occurring detections of the B Yamagata lineage virus since March of 2020. The WHO recommends that national or regional authorities should make decisions regarding the transition to trivalent influenza vaccines in their jurisdictions. And the Canadian National Advisory Committee on Immunization, or NACI, supports the removal of the B Yamagata strain from influenza vaccines as soon as practically possible, but anticipates a gradual transition from quadrivalent to trivalent vaccines due to significant logistical and regulatory challenges. These are the vaccines that are available this fall as part of the Ontario Ministry of Health's Universal Influenza Immunization Program, or UIIP. All of the UIIP vaccines are inactivated influenza virus vaccines, and there is one new addition for this season, the FluCellVax Quad, which is a cell culture-based vaccine, whereas all other UIIP vaccines are egg-based vaccines. Standard dose quadrivalent vaccines are available for all age groups 6 months of age and over, and there are 2 vaccines that are only authorized for individuals 65 years of age and over, the high-dose quadrivalent vaccine and the adjuvanted trivalent vaccine. The high-dose vaccine has 60 micrograms of hemagglutinin per strain compared to 15 micrograms of the standard dose vaccines. And the adjuvanted trivalent vaccine has the same amount of virus as the standard dose vaccine, but includes an adjuvant called MF59. Studies have shown that the higher antigen content in the high-dose vaccine or the use of an adjuvant in the adjuvanted vaccine can improve the immune response compared to the standard dose vaccine, which is important since older individuals may not respond as well to influenza vaccines compared to younger individuals. It is important to get the influenza vaccine because it is the best defense against getting and spreading the influenza virus. And the effectiveness of the influenza vaccine varies from year to year, depending on how well the strains included in the vaccine match the circulating strains. And it is also influenced by personal factors such as age and health status. For the last influenza season, the mid-season estimate from the Canadian Sentinel Practitioner Surveillance Network of the influenza vaccine effectiveness against medically attended acute respiratory infection due to influenza is about 63% for H1N1 and 40% against H3N2. Protection against infection and illness from the influenza virus through influenza vaccination may also provide added benefits of protecting against other diseases such as invasive group-based streptococcal disease or protecting against worsening of existing chronic illnesses such as cardiovascular disease. There are no changes to the influenza vaccine schedule for this influenza season. For individuals 6 months to less than 9 years of age who have never previously received an influenza vaccine, they should receive 2 doses at least 4 weeks apart. And for all other individuals, it's recommended that they receive 1 dose. Each year, NACI puts out a statement with recommendations for the seasonal influenza vaccine for the upcoming respiratory season. In this year's statement, there are no changes to the overall recommendation that the influenza vaccine should be offered annually to anyone 6 months of age and older who does not have a contraindication to the vaccine. NACI notes that the influenza vaccine is particularly important for certain groups, which are individuals at high risk of influenza-related complications or hospitalization, people capable of transmitting influenza to those at high risk, people who provide essential community services, and people who are in direct contact with poultry affected with avian influenza during culling operations. I'll talk about that last point a little bit later. This year, in addition to the annual seasonal influenza statement, NACI also released supplemental guidance for adults 65 years of age and older. And the supplemental statement included an evidence review with an overarching policy question of, should any age-appropriate influenza vaccine be preferentially used in adults 65 years of age and older? Outcomes of interest for the evidence review included vaccine efficacy or effectiveness, safety, and cost effectiveness. NACI concluded that evidence supports high-dose inactivated influenza vaccine, adjuvanted inactivated influenza vaccine, and recombinant influenza vaccine, which is not part of the UIIP, as having increased benefit as compared to standard dose inactivated influenza vaccine with no difference in safety. NACI stated that no definitive conclusion can be reached regarding the superiority of the high-dose vaccine, the adjuvanted vaccine, or the recombinant vaccine over one another. There is a limited number of studies directly comparing these vaccines against each other. And this evidence was used to inform the NACI recommendation for individual public health program level decision-making that the high-dose inactivated influenza vaccine, the adjuvanted vaccine, or the recombinant vaccine should be offered when available over other influenza vaccines for adults 65 years of age and older. For the Ontario Universal Influenza Immunization Program, it is recommended that vaccine is offered to the following priority populations as soon as it becomes available. First is residents, staff, and care providers in congregate living settings, individuals at high risk of complications or hospitalization from influenza, and healthcare workers, first responders, and individuals with significant exposure to birds or mammals. For those at high risk of complications from influenza, I want to highlight that in addition to older adults, children less than 5 are also a high-risk group for influenza complications, if they are not considered a high-risk group for COVID-19. Although infants less than 6 months of age are at high risk of complications from influenza vaccines are not authorized for use in infants less than 6 months of age because the vaccine does not work well in this age group. One new addition this year is the recommended priority populations in Ontario includes those with significant exposure to birds or mammals. In the NACI guidance, they only specifically highlight individuals with exposure to poultry infected with avian influenza during culling operations as a priority population for influenza vaccination. But the Ontario guidance has a broader recommendation that mentions other types of exposures, including poultry, livestock, slaughterhouse, and processing plant workers, wildlife officers, researchers, and veterinarians. This broader recommendation is consistent with the approach in other jurisdictions, such as the United States. Although seasonal influenza vaccines do not provide protection against infection with influenza H5N1 viruses, they may reduce the risk of co-infection with both a seasonal influenza virus and a H5N1 virus. And this co-infection could potentially lead to viral reassortment and the development of a human transmissible virus with pandemic potential. Following distribution of the influenza vaccine to priority populations as soon as the vaccine is available, influenza vaccination is recommended for the general population in Ontario starting October 28th. Influenza vaccine is recommended for all people 6 months of age and older without contraindications. However, individuals in the following two groups are particularly recommended to receive the influenza vaccine once eligible. First group is individuals capable of transmitting influenza to either infants under 6 months of age or to those prioritized to receive the influenza vaccine as soon as it is available. Second group is people who provide essential community services. For older adults in Ontario, especially those in congregate settings, it is recommended that they should get immunized as soon as the influenza vaccine is available for them. As highlighted in the NACI supplemental guidance for adults 65 years of age and older, the high-dose quadrivalent or adjuvanted trivalent vaccines should be offered when available over standard dose influenza vaccines. But it's important to note that if a preferred product is not available, any of the available age-appropriate influenza vaccines, including the standard dose quadrivalent vaccine, should be used. The most important thing for older adults is to be vaccinated, so it's recommended to not delay vaccination to wait for a particular product. And for additional information on influenza vaccines, please see these resources from the Ministry of Health, Public Health Agency of Canada, and the World Health Organization. I'll now turn things over to Dr. Reid Morrison for a discussion of RSV.
Okay, thank you, Richard. Respiratory syncytial virus is a very common cause of lower respiratory illness, and certain groups are at higher risk of severe disease, including infants and children under the age of 2, children with certain medical conditions such as chronic lung disease, older adults, and adults with certain medical conditions such as chronic lung or heart disease. And so today we'll discuss RSV prevention through immunization for older adults and then infants. There are 2 RSV vaccines for older adults that are authorized in Canada. Both vaccines consist of a recombinant RSV F protein antigen, which is stabilized in the pre-fusion form. That's why you will see pre-F in the name of both of those vaccines. And both vaccines are single dose administered intramuscularly. The GSK vaccine contains an adjuvant and is indicated for adults 60 years of age and older. The Pfizer vaccine is labeled as bivalent, as the protein antigen is based on both RSV-A and RSV-B subtypes. It's indicated for adults over 60 years of age and pregnant persons between 32 and 36 weeks gestation to prevent RSV-related illness in their infants. The two vaccines have similar effectiveness in preventing severe outcomes from RSV, with real-world evidence suggesting that vaccine effectiveness against RSV-related hospitalization could be 75% amongst all adults 60 years and older. Both clinical trial and post-marketing surveillance indicate that the vaccines are well tolerated, with adverse effects from RSV vaccination being mild and short in duration. The most common effects include injection site reactions, fatigue, headache, and some others listed here. Vaccine safety surveillance from the United States does suggest a potential increased rate in Guillain-Barré syndrome, or GBS, after administration of RSV vaccines in adults 60 years of age and older. However, there are limitations in the available data, and analyses are not conclusive. This potential association is being followed very closely. NACI has provided 3 recommendations for RSV immunization in older adults. At the program level, NACI strongly recommends RSV immunization programs for adults over age 75, particularly those at higher risk of severe disease, and for adults age 60 years and older who are residents of chronic care facilities such as long-term care homes. At the individual level, there is a discretionary recommendation that an RSV vaccine may be considered by adults age 60 to 74 in discussion with their provider. There is no preference for one RSV vaccine product over another in older adults. Ontario's publicly funded RSV program targets high-risk individuals and settings. The publicly funded program also includes those age 60 and older who are also residents of long-term care, elder care lodges or retirement homes, in hospital receiving alternate level of care, identifying as First Nations, Inuit, or Métis, and others listed here. Studies examining the need for and optimal timing of a subsequent RSV vaccine dose are ongoing. However, early data indicates that vaccine effectiveness against RSV disease can be maintained over 2 seasons. In clinical trials, revaccination in a second RSV season was well tolerated, but did not seem to provide additional efficacy benefit in the overall population. So those who received a vaccine last season do not need another dose this season. Moving on to RSV prevention in infants, there are 3 products that are authorized in Canada to prevent RSV-related disease. 2 are monoclonal antibodies, which are antibodies administered directly to the infant to provide immediate protection against disease. In Ontario, for the 2024-25 RSV season, nirsevimab will be the publicly funded product for eligible infants. The other is an RSV vaccine, which is administered to pregnant persons to protect their infants. This table compares the 2 products that will be offered as part of Ontario's publicly funded program. Both nirsevimab and the maternal RSV vaccine provide infants with short-term protection against RSV disease by passive immunity. Nirsevimab is indicated for infants and high-risk children up to 24 months of age before or during the RSV season. Because it provides infants directly with ready-made antibodies, protection is immediate and may last up to 6 months from administration. It is administered intramuscularly as a single weight-based dose per season. The RSV vaccine is indicated for pregnant persons between 32 and 36 weeks gestation who will deliver during the RSV season and is administered as a single dose intramuscularly. It takes approximately 2 weeks for the pregnant person to produce antibodies in response to the vaccine. Protection is provided for up to 6 months after birth. Nirsevimab has shown to be very effective against hospitalizations and ICU admissions in clinical trials and real-world settings. It is very well tolerated, and the most common adverse effects being rash, fever, and injection site reactions. RSV vaccination during pregnancy has shown more moderate effectiveness against hospitalization and severe RSV disease. Common side effects in pregnant persons are mild and short in duration, such as injection site reactions or fatigue. In clinical trials where the vaccine was administered as early as 24 weeks of gestation, there was a slight and non-significant increased rate of preterm births in those who received the vaccine. In a more recent study from New York with pregnant persons receiving the vaccine between 32 and 36 weeks, there were no significant differences in preterm birth rates between the groups. NACI has recommended that provinces work towards a universal RSV immunization program for infants, with the product of choice being nirsevimab. If a universal program is not implemented, there are further recommendations seen here for prioritization of different groups of infants. At the individual level, NACI recommends that RSV pre-F vaccine may be considered by pregnant persons in consultation with their provider. In terms of Ontario and in alignment with the NACI recommendations, there will be a universal infant RSV prevention program in Ontario this RSV season. Children born in 2024 or during the upcoming RSV season are eligible for nirsevimab. As well, certain groups of children who are at higher risk of severe RSV disease will be eligible for nirsevimab in their second RSV season, including those with chronic lung disease, severe immunodeficiency, and others listed here. Although nirsevimab is the preferred product for RSV prevention in infants, pregnant persons who are residents of Ontario may discuss RSV vaccination with their provider. For example, in situations where nirsevimab would not be agreed to or be available. However, if the infant is anticipated to receive nirsevimab, then RSV vaccination during pregnancy may not provide any additional benefit. There are, however, some infants who are recommended to receive nirsevimab even if their parent received RSV vaccine during pregnancy. This includes all infants who are born less than 2 weeks after their parent received the vaccine, all premature infants, and other infants who are at higher risk of severe disease. I'll encourage everyone to consult these excellent resources. I will also highlight that there are some patient-facing resources available through the Ministry of Health that cover important information, but in plain language. Ongoing surveillance of adverse events following immunization, or APHEs, is essential for monitoring vaccine safety and maintaining confidence in immunization programs. And more specifically, it's the reporting of APHEs from healthcare providers to their local public health unit that provides important vaccine safety data. When you report an APHE, you provide vital information that is needed to monitor vaccine safety. As this reporting is mandatory for healthcare providers, I would encourage you to see the vaccine safety webpage on the PHO website or your local public health unit for further information and reporting. Please note that as a monoclonal antibody, nirsevimab is not a vaccine and therefore not subject to mandatory reporting. Your organization may have existing practices in place for reporting medication side effects. Side effects for nirsevimab can be reported using the relevant Health Canada side effect reporting form. COVID-19, influenza, and RSV vaccines are examples of inactivated vaccines. In general, these can be administered with or anytime before or after other inactivated or live vaccines. So the RSV, COVID-19, and influenza vaccines may be co-administered. It is also unknown how the adjuvants in Fluad and Shingrix may interact during co-administration due to a lack of clinical trials. And at this point, I will pass it back to Tara. Thanks.
Thanks, Reid and Richard and Sarah, for your presentations. We have lots of time for questions, so we'll move into the Q&A portion of our session. Just a quick reminder to our audience to continue to enter your questions into the Q&A pod if you haven't already done so, and we'll get to as many as we can during the time that we have. And a reminder that we'll just focus on questions related to the vaccines and immunization programs outlined during today's session. We'll just go to the Q&A, and I've got a first question related to COVID vaccines. So the question is, given COVID vaccines in the past have been given outside of the window of the last infection, how will this be handled this year, given rapid tests are no longer available? So people will most likely not know when their last infection was.
Thanks, Tara, and thanks to the participant who posed this question. So I think that this is in part related to some of the language I described from NACI, and it's also been incorporated into the provincial guidance, which notes as a consideration that individuals and immunizers may consider delaying COVID-19 vaccination by 3 to 6 months in cases where someone is aware, i.e. have test-confirmed infection. But the corollary is also true that if individuals have not had a test-confirmed infection, they may have had symptoms, but if they don't know whether it was COVID or another respiratory virus, they would be recommended to receive the COVID-19 vaccine without any barriers put in place due to, a history of symptoms without any diagnosis or test confirmation.
Thanks, Sarah. There's actually, maybe we'll do a couple more on COVID vaccine and then see what we have for influenza and RSV. So another question, which I think is a question of clarification around the VE figure that was presented and why you think there is a wider confidence interval for that adult age group, 18 to 64. The question is whether they were potentially underrepresented or have lower vaccination rates. Any comment on that?
Yeah, another really great question. So this isn't about vaccination rates, but has to do with the likelihood of seeing hospitalizations in these different age groups. So we know that people over 65 are more they're at greater risk of hospitalization compared to younger individuals. And so the wider confidence intervals is sort of what we'd call an issue of precision. There's just fewer events in that age group. And I saw this in the chat and I looked up in the figure. So in the 18 to 64 age group, there was only 114 hospitalization events. And that's compared to in the 65 plus age group, almost 800 hospitalization events. So when you have more events, you can produce tighter confidence intervals. So that's really what we're seeing. And that's also why I was sort of suggesting that we look at the 65 plus population, because that's where we tend to see the greatest risk of hospitalization. And also then as a consequence, sort of see those sort of tighter confidence intervals. So thanks, that's a great question.
Thanks. Okay, one more on COVID vaccine and then we'll switch to something else. Anything or any comment on the differences in side effects or vaccine safety profile between the Moderna and Pfizer products for this season? Anything different about this season to note on that?
Yeah, so we don't have any indication from last year or previously to suggest that the vaccines, Pfizer and Moderna, in the dosages that are currently used in the program would have any differential safety signal or differential risk of side effects. So I think the answer is no, simple no to that question, and thanks for posing that.
Okay. And I want to take advantage of having our panelist here, our additional panelists, Dr. Warshafsky. So there's a couple more sort of like programmatic questions here. A question about, this is on RSV, when can primary clinics expect to receive Beyfortus? Can primary care clinics order Brisvo or Arexvy from the public health units?
Yep, a Brisvo and Arexvy are available now. This year is primarily a Brisvo. There's a little bit of Arexvy still left over from last year, but that's been available to order for basically since September for primary care. Our Beyfortus supply just arrived, the 100 milligram doses basically this week. So primary care providers can start ordering from public health units and should be able to get distribution within the next week or so. The 50 milligram doses aren't yet in the province. Those will be coming in another couple weeks. They're primarily going to hospital for newborns, but if primary care does need some of the smaller 50 milligram doses for newborns, that'll be coming in a few weeks.
Great. And a couple other RSV questions. Maybe Reid can have a go at addressing some of these. So the question was about repeated doses of RSV vaccine. So would RSV, the question is of clarification, would RSV vaccines be given every 2 years, given they're not expected to be re-administered this year? So maybe just clarifying that question.
Yeah, of course. So at this time, they're due to the lack of, or I shouldn't say lack of, but due to just ongoing trials and data that is coming in, there is not a confirmed timeline in terms of repeat vaccination in subsequent seasons at this time, but of course, being followed very, very closely. So at this point, if somebody had received a vaccine last year for RSV, it's not indicated to receive another dose in this season.
Okay, thanks. And actually, a sort of related question about if there are estimates for vaccine impact or effectiveness in Ontario for RSV vaccine available, or maybe a broader question of when that type of information would be expected.
Yeah, so at this point, as we discussed, in terms of the population of that received the vaccine in Ontario, this was targeting individuals in higher risk settings, such as long-term care. To the best of my knowledge, we do not have a published study at this point indicating presumably when we're saying impact, things like averted hospitalizations or RSV-related outbreaks. At this point, we don't have that data published, but what I will say is that there is quite a bit of vaccine effectiveness data that has been published related to both of the RSV vaccines for older adults. Including in individuals who are in chronic care settings, but also community dwelling adults. I think this information, like that research, is very, very well summarized in the NACI statements on immunization, like RSV immunization of older adults. At this point, though, like I said, I don't have or I'm not aware of any published data for vaccine effectiveness or impact squarely in the Ontario population.
Thanks, Reid. There's a question here, which maybe is for all of our speakers, but maybe I could start with Daniel around highlighting maybe resources that are available for the public related to fall immunization guidance that can be used in community health promotion efforts.
Sure, that's broad, given we talked about so many things. I would always like to first direct people to our Ontario Ministry websites, which contain all of the guidance documents that you would need as a healthcare provider. There's sites for RSV, flu, COVID, etc., and all the guidance documents are found there. There's also public-facing websites as well for all of those that give kind of the high-level information of what the public would need to know in terms of the eligibility for the programs, how to locate those products if you're looking for them, etc. If we're talking about more like patient-facing resources that you could print out, we do have some handouts on those ministry websites as well, but there's also lots that have been done from like all of our local public health units and other organizations that have put out handouts that are a little bit more easy for patient-facing materials as well, and could probably give a long list that we can share after this.
Okay, great. Another question actually for you, Daniel, after this question about after this year will RSV continue to be publicly funded?
Yeah, it's a good question. So at this point, it looks like, yes, that we're going to continue to have at least a high-risk program for RSV. I assume I don't know if they're talking about vaccine or Beyfortus for infants, but both programs at this point are slated to continue every year. Whether there'll be changes or expansions to the programs, that's not been decided as of yet. But we will continue to have a comprehensive RSV prevention program across the lifespan.
Okay, thank you. Maybe a question for all the speakers as well. There's a few questions about this around just communication strategies and suggestions from our speakers about how to address misinformation, disinformation related to specifically COVID-19 vaccine, but all vaccines, and any strategies that you recommend.
Happy to kick us off with that. I think that's a really important but also really challenging question. And I think we've all seen the impact of vaccine misinformation and disinformation. And I think sort of the strategies are probably multi-level and long-term to really address the main and core issues. But I wanted to highlight something that I think we know to be true from many, many years of immunization research, which is that for many or lots of studies demonstrating that for individuals, the most important, impactful thing influencing their decision to be vaccinated is a recommendation from a trusted healthcare provider. And that is agnostic to the particular vaccine. It applies to multiple different vaccines and vaccine platforms. I recognize it's very time intensive in terms of the kinds of questions that healthcare providers are responding to and addressing, but I think it comes down to receiving information from someone who is trusted. And I think that is, a really important component in individuals choosing and deciding to be vaccinated. So I think that's sort of a strategy that's cross-cutting across all vaccine programs.
Thanks, Sarah. A couple of clarification questions that I want to get to. So there's one about the Abrysvo. So RSV vaccine, is Abrysvo publicly funded for patients greater than 60 if not at high risk?
No. At this point in time, it's only for those particular high-risk groups. So it's predominantly individuals living in long-term care homes, retirement homes, elder care lodges, as well as that other list that was mentioned about specific high-risk medical conditions. It's not broadly available for just all individuals over 60 at this time. It is available on the private market for those who are interested.
And another question about, so this is around the coverage uptake reporting that happens from long-term care facilities. So in addition to influenza, will RSV also be required in terms of submitting rates from long-term care facilities?
So this at this point, what was completed last season was RSV vaccine uptake amongst residents of long-term care only. So at this point, we're still discussing whether or not this will continue longer term and the format of the reporting of vaccinations amongst residents in long-term care homes. But just for clarity, this is as opposed to the annual survey that the questioner is referring to, that often includes staff and residents in facilities, including long-term care homes, but also hospitals. For this, the RSV vaccine would not be asked of all staff in all facilities. It was, at least last year, isolated just to residents of long-term care homes.
Thanks, Reid. Question about Moderna vaccine, clarification of recommendations for Sarah. So previously, Moderna vaccine was not recommended for people under age 30. Is this still the case for the booster?
Great question. No, so they're either product, Moderna or Pfizer, can be used. And that recommendation changed some time ago. It's not new for this fall, but just to reiterate that either product, Moderna or Pfizer, can be used as a booster dose for all ages. And that's after a careful review by NACI, looking at rates of myocarditis and pericarditis by age, and seeing that this dramatically was reduced for booster doses compared to the primary series. And as I sort of highlighted or alluded to earlier, the dose of the Moderna product now is 50 micrograms for adult age groups compared to 100 micrograms previously. So there's probably lots of different potential reasons for why we're seeing differences with booster doses, but that's one possibility. But the key message is that either product is recommended, either product can be used for all age groups. In relation to booster doses, and of course follow the directions in terms of the actual product. There's two different dosages for Moderna for younger children, as well as adolescents and older, and as well as adults.
Thanks, Sarah. This is maybe for Reid, or I know you covered the slide on co-administration. I think it's just a clarifying question, but the example is in residents over 65 years of age. Can you administer RSV, influenza, and COVID-19 vaccine on the same day in a separate site?
So the answer is yes. I think they may be co-administered. If you are a patient-facing provider, you can discuss this with the resident or with the patient in terms of their preference. But I would just highlight that, of course, there are some of the issues surrounding co-administration, such as not having missed opportunities for vaccination, is part of the reason why we're trying to highlight this message that they may be co-administered. So of course, discussion with the patient is important, but recognizing that you can really enhance vaccine uptake with co-administration as one strategy is something to consider.
Okay, we'll get to a flu question here. So there is one question related to sort of requesting clarification or to expand on the importance of influenza vaccine recommendation this year for those that have significant exposure to birds and mammals.
I can take this one. So as I stated previously, the seasonal influenza vaccine will not protect against H5N1. But individuals with significant exposure to birds and mammals may potentially be exposed to the influenza A H5N1 virus. We haven't seen any locally acquired cases in Canada, but there have been a number of cases in the US associated with exposure to dairy cattle and poultry. So the seasonal influenza vaccine may protect individuals from being co-infected with both the seasonal influenza virus and the H5N1 influenza virus. And if you are co-infected, it could lead to more severe infection in the individual, as well as potential for reassortment, which is parts of the seasonal virus and the H5N1 virus being combined together to create a new virus, which could potentially have the severity of an H5N1 vaccine with the easy transmissibility of a seasonal influenza virus. So we want to prevent the development of that, as well as prevent severe disease in the person.
If I can add quickly, Tara, not as scary as what Richard was saying, but there's also a programmatic standpoint of this, which is just to get that population used to receiving the vaccine more often. We've seen that work in a lot of other jurisdictions globally, such as in Scandinavian countries, where they've been working closely with those providers for such a long time that when they do have the avian influenza vaccine available, they're kind of ready to give it. And so part of that is starting to build those connections in and making it normalized in that population. Also, the scary things Richard said.
Thank you both. There's a question about the RSV season. So will the RSV season always be defined as November to March for the RSV prevention program, or might there be room for regional variation or provincial modification based on this season's epidemiologic data?
Yeah, if it's okay, I can start with that one, Reid. So in terms of the season start, we've had a lot of discussion with our RSV advisory group, and given the fact that we have really good confidence in how long the product of Beyfortus lasts, frankly, for infants, probably it doesn't look like we'll be needing to declare an official start to the season anymore. Rather, it'll be as soon as product arrives at a reasonable time, hopefully earlier than this next year, that we can just start administration right away because we're confident in terms of coverage. We'll still at this point be looking at a season end date to when we should stop administering. And I think after this year, we'll have a much better sense of whether or not that's something we need to keep doing as well, or if we're going to stick to a more regular time period. But for now, it looks like season start is going to be essentially when we're going to start the actual program administration, as opposed to what we've done previously with Synagis, which was we have to call it so that we're limiting the number of doses that are going out.
Okay, we'll go to Richard. There's a question, actually a couple of questions that are related about clarifying if there was an interaction between flu vaccine and shingles vaccine, and if there is, how long to wait between administering.
So guidance from NACI states that the influenza vaccine can be given at the same time or at any time before or after another vaccine, including the Shingrix vaccine. They do note that there's no studies directly comparing the co-administration of the adjuvanted influenza vaccine and the adjuvanted shingles vaccine to see if there is a potential interaction. But they don't state any contraindications to co-administration. There is a comment from the ACIP in the US to say, consider giving a non-adjuvanted influenza vaccine if you are going to be giving the adjuvanted shingles vaccine at the same time, but that you should not delay vaccination to obtain a non-adjuvanted one.
Thanks, Richard. One question that was actually posed ahead of this session, which maybe wondering if Daniel can comment on, is it's related to the previous question about like what information is available for the public, but what promotion materials are available specifically to notify parents, make them aware of the RSV program this fall, winter, since it's a new program, and any information on the risks and benefits for parents.
Yeah, and again, there are those general ministry materials that are on our website. There's been a number of other organizations that have put out some really, really good products, though. I'll call out PCMCH, the Provincial Council for Maternal and Child Health, has like a wonderful little patient foldy handout thing that you can get for your offices and give out, which is really, really well done. There's also some documents out from Immunize Canada that are really, really helpful as well that I direct people towards, and those can be used. So lots of really good materials looking at, and again, I'm sure many public health units as well have been distributing these at the same way.
Great, thank you, Daniel. And I think we're just about at time, so I'll head into our wrap up, and I'd like to extend my thanks to Sarah, Richard, Reid, and Daniel. Thank you so much for joining us and for the excellent presentations. I'd also like to thank everyone who attended today's webinar. We appreciate your participation and your great questions. You can expect to receive a brief survey after today's session, and please try to complete this as it does help us improve our programming. And lastly, to access past PHO presentations and to view upcoming sessions, you can visit the PHO website and go to Education and Events and click on Presentations. So thank you very much and have a wonderful day.